Welcome to Kellogg, and thank you for joining us today for the seminar, which is around community well-being and how it can be supported in the neighborhood. My name is Astrid Krisch. I'm a postdoctoral research fellow here at GCHU. GCHU brings together the research interests of the college, in particular around sustainable urban development, health and well-being, and evidence-based medicine. Our public seminars aim to bring together different voices to address some of the key challenges faced by society today. So I'm delighted to chair the session today of this evening's event, and I'm going to give just a very brief introduction to the theme to set the context for this evening's discussion before introducing you to our speakers today. As we all know, global and regional health inequalities are on the rise, including unequal access to health care, resulting in unequal health outcomes and life expectancies for different populations in different regions. Healthcare systems worldwide are struggling from strained resources, increasing demand, workforce shortages, and the need to move to more sustainable systems. Current disease management also often focuses on treating individual conditions without a holistic approach to well-being. So there's an urgent need for comprehensive reforms and innovative solutions to ensure that everyone is given an equal chance to health and well-being. And in this regard, community well-being can serve as a cornerstone in addressing these global and regional health challenges. Community well-being as the collective well-being of a group of individuals or a community is the result of different interacting factors, including the relation between the community and its neighborhood features, such as the walkability of our streets, or social factors such as social cohesion, family structure, or place attachment. So community well-being is based on the provision of foundational infrastructures and services, but also it is much more than that. It depends on the relation to place and to purpose, emphasizing that communities are complex ecosystems shaping our lives, our health, and the lives of those around us. So community captures the essence of life as it is lived and experienced together. It demands both assessing individual and population well-being and considering them within the context of community life. In the past decade, there's been a growing interest in understanding what constitutes a good life, what it means to live well within limits. The focus on subjective well-being has led to new indicators and policies, but community well-being remains a relatively new and underexplored concept. So today we are going to look at how being well within the community can be better understood and supported, what role space and place play in that, what the evidence says about community well-being, and how this evidence can be used to inform decision-making. So I'm delighted to welcome our four excellent speakers for this evening, who will, through their presentations, provoke and stimulate our discussions for our Q&A and help us to reflect on how community well-being can and should be supported in a neighborhood. The structure today is we got four experts who are each going to pitch their perspective on community well-being. Then there will be an opportunity to ask questions to our speakers, and following that will be a drinks reception where you can network and discuss these topics further. So without further ado, I'm delighted to introduce our first speaker of today, Ansaf Azhar. He's Director of Public Health and Community Safety at Oxfordshire County Council, and he's working towards promoting healthy behaviors and thriving communities whilst reducing inequalities across Oxfordshire. Welcome, Ansaf, and thanks for joining us.
Hi, everyone. Can you hear me all right? Okay, excellent. Thank you, Astrid. So my name is Ansaf Azhar. I'm the Director of Public Health for Oxfordshire. So I've been in Oxfordshire for about 4 years now. Started 6 months before the COVID pandemic. So, actually, one of the things that struck me about Oxfordshire is the kind of the nature of tale of two counties, if you like. It's got two sides to the county. So what I want to do in the next kind of 5 minutes is to kind of give a little bit of Oxfordshire perspective, specifically around the inequalities within Oxfordshire, and then hopefully end it in a way to say, what is the role of place shaping or healthy place shaping in tackling some of those inequalities? So if I can land that piece, hopefully spark up a debate around that, that would be job done. So to start off, so my previous role, I was a DPH, Director of Public Health in Sandwell, in inner city in West Midlands before I came here, and actually very deprived. All the health indicators really not great. And I came into Oxfordshire, and this was the picture. It was green. Pretty much every indicator I looked, we were doing well. And I just kind of scratched my head and thought, well, what's next? So when you dig deep into that, this actually formed the basis of my first Director of Public Health Annual Report as well. So when you dig deep into that, and you look at certain areas, and you look at, there were 10 wards in Oxfordshire that had lower super output areas, specific areas, that are in the 20% most deprived in England. And actually, this is, you know this, and actually when you repeat the same health indicators for those, they turned out to be one of the worst in the country. So it's quite stark. And I think if you look at hospital admission, premature mortality from heart disease, respiratory disease, they all came unequally from these communities, these areas, and so on. That doesn't mean we just focus on specifically on these areas, but there is a kind of a proportionate universalism approach that needed to be applied. So if you repeat that same thing across all the different wards that we have in Oxfordshire, you see the same story again. There's clear divisions. You've got the England average, Oxfordshire average at the top. Oxfordshire is much bigger. Better than England average, and then you have the districts, and then you have the individual wards, and you can see the division there quite clearly from a life expectancy point of view. Then you can, as I said, you can repeat that to pretty much every indicator that you can think of, whether it's emergency hospital from respiratory disease, obesity at year 6, some of the wider determinants. You will see that Oxfordshire is better than England average, the red line. But actually, when you go down to individual wards, which are the grey ones, you see a different picture altogether. And that allows us to kind of target while we're providing universal provision. Same for other things like more wider determinants elements like educational attainments. You see the same pictures. You see the division between wards. Some wards are, well, some of the most affluent wards, you see much better educational attainment, and then the other disadvantaged communities, you see a different picture altogether. So I think the point I'm trying to make is that we are in a bit of a transition. We often think healthcare, spending money on healthcare. I mean, if you take a guess how much we spend within Oxfordshire, we spend over £2 million a day on healthcare systems just within Oxfordshire. But if you think about what determines health and well-being, it's only 20% of them are counted by healthcare system. Let's just think about that for a minute. 20% of healthcare system, and I just told you how much you spend in a daily basis in Oxfordshire. The rest of the 80% is on built environment, socioeconomic factors, and health behaviours, and so on. So just to really simplify this, so essentially, if you ask the question, why do we have high levels of chronic illness in certain areas? We spend a lot of money and time and effort on tackling illness, which we have to, but they're essentially driven by lifestyle behaviors. We have got disproportionate poor lifestyle behaviors in certain communities, certain areas. And we will spend the whole noughties and the 90s educating people because we thought that was the best thing we can do. Let's educate, let's personal responsibility, let's do all that. And what we found out is that actually it's more than that. There are mental well-being and social wider determinants elements that drives those behavior, which we need to tackle. And you can't tackle that purely by education alone. You've got to look at your place, you've got to look at the community, and this is where, for me, the community well-being element comes in quite strongly. So I call this the prevention spectrum. So if you think about this triangle, we spend a huge amount of effort on kind of population health management, long-term disease management. But actually what we need to do is to occupy that space of healthy place shaping communities and assets. Because if we know that pound per pound, if the amount of money you spent on it, you will get a much bigger return and have a prolonged impact. Now, the evidence, we all know it's good. The tangible evidence, is lacking because it's always difficult to prove causality when things are multifactorial, and that's the challenge often we have. So that hence the concept of healthy place shaping. What does healthy place shaping mean? Oxfordshire has kind of pioneered this because in 2016 there were 10 new healthy towns. Oxfordshire had 2 of them, Bicester and Barton. And the whole concept is to create a place that promotes healthy behavior and thriving communities. So all the things that I've showed earlier, it's tackled by that upstream action, and you're tackling the structural determinants of health. So it'll create healthy built environment, healthy behaviors are norm, so you're not spending money tackling the effect of unhealthy behaviors. You create places where people are socially connected, which has a sense of belonging and has better mental well-being and so on. So there are, when the Healthy New Town concept was launched, there are 3 key elements. There's the built environment, there's the community activation, and then there's new models of care, delivering care in a different way. Okay, those are essentially the 3 pillars of healthy place shaping. So built environment, I've already tackled this. This is about creating places that where being physically active becomes a norm, secure environment, creates more social capital, integrated communities, and so on. You can build these things, but if you haven't engaged with the community, if you haven't activated the community, that will not work. So you can build cycle lanes and you can build pedestrian street, but if you haven't activated the community to be able to make them more confident to cycle and things like that, that's not going to work. And that's what community activation is about. It's about how do we do that in an asset-based way with the community. And it can be very, very simple things. We did some projects where we just changed the environment. We took those metal bollards and put those the wooden bollard there, which actually increased the access to green spaces. Training for Black and ethnic minority community around cycling. So these kind of simple things has made a significant difference in terms of improving physical activity and so on. So, I mean, this is my last slide, but in essence, it's about creating a space and tackling some of the underlying drivers of inequality through healthy place shaping, and these are some of the things that will actually help to some of the benefits of healthy place shaping that will help to promote those behaviors in a positive way. I'm happy to take questions on that, but hopefully that helps to kind of set the scene around some of the discussion we can have later. Thank you.
Thanks very much. Next up we have Joanne Smithson, who is Head of Implementation and Learning and Local Government and Health Sector Lead at the What Works Centre for Wellbeing. The centre is the UK's national body for wellbeing evidence, policy and practice, and Joanne's work aims to understand what local government, health organisations, communities and individuals can do to increase well-being and effectively translate this into practice. Welcome, Joanne.
Thank you, Astrid. I'd just like us to take a little step back. We're going to be spending a lot of time in the next hour talking about health and well-being, but what do we think of when we talk about those concepts? If you think about health, what pictures you reflect, what are coming to mind when we talk about health? Might be about healthcare, your local NHS or local services. Might be about the presence or absence of disease. What about well-being? I'd like you to think about a time you had high well-being. What did you feel? And what was the cause of that? What was the activity that gave you that feeling? Just spend a couple of minutes and chat to the person next to you and just share that moment of high well-being with them. And ask you to make social connections. Okay, I'm conscious I've got 5 minutes, so I'm going to draw you to a close there. Okay, folks. I've committed the cardinal sin of getting you all talking. Okay, so hopefully when you were talking about those areas of high well-being, I could hear people talking about meeting with friends. I could talk about heard about connections, playing with grandchildren, I think I heard over there as well. And I think the really interesting and exciting thing about working in well-being is it's subjective. So what matters for me and what's important for me will be different to every single one of you in the room. That subjective nature of well-being gives us the richness, those emotions. But in policy making, that's a bit more tricky, isn't it? So whilst health is broadly objective in that we may have disease or not, well-being is that subjective feeling. We often think about well-being, individual well-being as feeling good, functioning well. That's quite a good framework for that. What about community well-being? That's being well together. It's not really just adding up the sum of the well-being of the individuals in a place, is it? It's a bit more than that. And that's because it's being well together. So it's those connections that really start to play a part here as well. And it's about that distribution of well-being in a place. So where are those opportunities for people to live healthy and fulfilled lives? How are they distributed in a place as well? That well-being inequality angle. When our centre was set up almost 10 years ago now, we did a series of public dialogues. And just like I've asked you, we asked, over 5,000 people in the community, what does high well-being mean to you? And they came back with 3 areas. They talked about feeling safe. They talked about feeling loved, and they talked about feeling fulfilled. How often do we policy make with those 3 goals? I'd argue not as often as we should. So, feeling safe in a community setting, what does that feeling look like? Well, it's about the places and spaces. As we've heard, it's about accessibility, but it's also, if you take a well-being lens, it's about how often we might see people like us using those spaces. It's a sense of belonging. Safety itself, that fear of crime and actual crime is important, but precarity too. So how in our neighbourhoods are we supporting people around housing and housing tenure, around income precarity and job security as well? Really core tenets of well-being and health. What about feeling loved? How do we do that in a neighbourhood context? So those relationships that sustain us and support us are really key here. And that's relationships across the life course. So it's that best start in life and parental well-being. It's about meeting, coming together, but it's also about families and relationships coming apart. How do we support people when that happens as well? It's about well-being across our life course. The biggest predictor of our adult life satisfaction is our emotional well-being at age 16. It's not the number of GCSEs that we have. How often do we capture and record that data? We know, for example, one of the biggest challenges around people caring for a partner with dementia is around the loneliness and isolation that can bring as well. So how do we use neighbourhoods to sustain relationships across our life course? Then that last one, feeling fulfilled. So that's about having purpose and meaning in our lives. It's about being able to learn skills and knowledge just like we're doing together today. It's about supporting others as well, so that fulfillment, being able to support and enable. So I think in sort of conclusion for me, it's about how do we do feeling loved, feeling safe and feeling fulfilled at a neighbourhood level? How do we bring the evidence of what we know works in that space alongside that? Making sure it's practice-led, so the people on the ground supporting, putting those programmes together, being able to shape what they know will work in their context. And it's also about listening and hearing people's lived experience and making sure we reflect that as well. Thank you.
Thank you very much, Joanne. Next up, we have Professor Jane South, who is Professor of Healthy Communities at Leeds Beckett University. Jane works in the field of community engagement and public health, and her research includes looking at how community life and volunteering contribute to good health. So welcome, Jane.
Thank you. Good evening, everybody. My starting point to answer the question is we know that where you live, including at the kind of quality of your neighbourhood, matters for your health and well-being. But I want to highlight that there's a huge wealth of evidence now, particularly in the last decade, that suggests that the quality of social relationships really matter for physical health, well-being and recovery. So whether you have social support or are isolated, the levels of trust in your community, whether you have wider connections and access to wider social networks, these are all relational factors which are critical. And I suggest that they are not taken as seriously by policymakers and in planning for better health. And this is all compounded by the problem of health inequalities, which is driven by the inequitable distribution of social, economic and environmental resources. So what can we do about this? I'm going to set out 3 propositions based on the idea that we need to move beyond thinking about the place as simply a geographical entity or an administrative unit like a ward, to thinking about the relational aspects and the sets of connections within that neighbourhood. So my first proposition is that we should try to understand the assets as well as the deficits or needs within a community as our starting point. Broadly, asset-based approaches seek to surface and mobilise the assets that are in the social resources that are within communities and use these as the building block for developing practical action with and by communities that will improve neighbourhoods. And this sounds common sense, it does to me, but this is actually a really radical idea because it doesn't start with administrative categories or the ways in which obvious assets like schools or parks. It starts with the assets that the communities identify. So it could be that babysitting circle. It could be the group of volunteers who care for a piece of green space. It could be some individuals' local history, their knowledge of the area, or how a pub or a library gets used as a hub. And also with asset-based approaches, there's an attempt to see the rich tapestry of voluntary and community organisations, large and small, in an area. And by thinking this way, you can start to see a different view. Instead of often policymakers, health planners see the community as a blank canvas to then develop an intervention on, you start to see the community as an ecology which provides the foundation in which to build better health and well-being and to layer in public services to address needs. My second proposition is about investing in social infrastructure. And I was really interested this year because the US Surgeon General published a report based on committee evidence, bringing together really a compendium of evidence around what is called the healing effects of social connections and community. And one of their big recommendations for the American health system is to invest in social infrastructure. And I think many of their recommendations also relate to the UK. But of course, social infrastructure is a bit of a woolly word, isn't it? What does that mean in practical terms? So based on the best evidence that I've either collected or seen or whatever, I would suggest practically you could invest in 2 bits of neighbourhood. Firstly, thinking about community hubs and community anchors. You probably know some of these already in Oxford, but these are the community-based organisations often delivering a whole range of different services across the wider determinants of health, you know, training, employment services, social care, etc. And they also tend to provide safe spaces in which people can come to collect, so they're open to the public, perhaps have a cafe and so on. These community hubs and anchors are an essential bit of our infrastructure, and they need to be taken into account when we're developing well-being. trying to develop wellbeing at a policy level, because a lot of the evidence shows that they're an excellent platform for developing social relationships and connections in our communities. The second focus I would do would be to focus on widening opportunities for volunteering, because this will bring wellbeing benefits for the volunteers, but also wellbeing benefits to the community, particularly when we focus on inclusive volunteering, which is where we're opening up volunteering for underrepresented groups, for example, people with physical disabilities, and enabling them to participate, which actually recognises their skills, knowledge and connections. And this can be critical for dealing, addressing some of the health inequalities issues, because underserved communities are often quite sort of disconnected, and involving volunteers from those communities starts to bring those connections in. So, and if you think, does this sound a bit, too sort of nice, community-wise, think about the pandemic. Because when you think about, and I'm sure all of you will have experienced that, the essential role of volunteering and community hubs in maintaining and promoting wellbeing in that emergency, you can see how critical they were to the public health system then, and we need to maintain and continue to invest in that social infrastructure now in our recovery period. So finally, just a little bit very quickly about the third proposition, because we're in a university, I thought I'd better say something about knowledge and research. But we need, I think, a refreshed evidence base that takes account of the importance of social relationships and seeks to understand community systems. That means we need to think about how knowledge is gathered, who's involved in gathering that, and what outcomes matter. And I would suggest this is not a stage of the baby, taking the baby out the sort of bathwater, so to speak. This is about having a better understanding of the relational factors alongside all those other things that we understand quite well. But in doing so, this will help us promote and recognise the importance of community wellbeing, and also help us reorientate and redesign our public services. Thank you.
Thank you for that, Jane. Next up, we have Simon Zedinsky, who is Executive Director of the King's Foundation, formerly known as the Prince's Foundation. The charity's focus is to create communities where people, places, and the planet coexist in harmony. And Simon is overseeing the organization's education, health, and other charitable activities. So thanks for joining us, and over to you, Simon.
Thank you. Lovely. Thank you. What I thought I might do this evening is give just a bit of a case study of a community health initiative that we have done, and I think ties in really well with what's been said earlier, and might just sort of talk a bit about how these are put into practice and implemented. So just very briefly, I won't spend too much time on introducing us, but by and large, we are an organization that sort of bridges education and practice broadly within the fields of sustainable development and community building, often at the sort of intersection between our sort of natural and built landscape. And that takes the form of education and training, around 15,000 students a year from sort of primary school to PhD, research, convening, and the like, as well as the sort of development, management, and regeneration of assets across the UK, be that sort of from a master planning side of things through to the maintenance of a series of heritage assets across the UK. And it's one of those in particular I wanted to talk about this evening. And that is a place called Dumfries House, which, if you haven't heard of it, which many of you probably have not, is in Ayrshire in Scotland, in East Ayrshire. And a very, very brief history, which was that it was a private residence. It was probably famous, most famous at the time, for a remarkable collection of Chippendale furniture, probably one of the world's sort of leading collections. And long story short, it was going up for auction because of a series of deaths in the family that owned it and death duties, and the collection was at risk of being scattered to the globe. So the initial interest in sort of protecting, preserving the house was really focused around preserving that collection, but it really quickly became apparent that this had the opportunity to be so much more than that. It could become an exemplar for sort of heritage-led regeneration, the role that this estate could play within its community. East Ayrshire is a very deprived community, top 5% in the UK, and it is an area that really was heavily reliant, among other things, on the mining industry. And when the mining industry collapsed, so too did the local economy, which had huge impacts on outcomes around health, economics, social outcomes, and a range of others. So what we really saw on taking over the estate and the property was how can we use this as a driver for community development and community building. And a big part of that is now, 15 years later, 7 education centres across the estate, across a range of curriculum areas, a huge number of community assets, hundreds of thousands of visitors a year. The estate is free, it's open 24/7, but it also is a really creative, hopefully, use of how the estate and the natural environment can also be drivers of well-being. And so I wanted to touch a little bit on our Health and Wellbeing Centre there in particular. So one of the first things that we did on taking over the estate was convene a group of local stakeholders, well, many groups of local stakeholders. And one of those was around health and well-being. How could the estate become a driver for better health and well-being within the community? And so that involved bringing together all of the local healthcare practitioners, GPs, and others, as well as community groups, community leaders, community residents, and a range of others to understand what was the need in health and well-being in the community, where was there a struggle within the sort of formal systems to meet that need, where could support be given. And as you can possibly imagine, out of that came a laundry list of areas where they could value sort of support and help within that system. But we really honed in on some of those that really shone in that process as being key areas. And that's very place-centric. It would be very different in another place. So this was very much focus on what that local community had identified. And so some of the programs we run are everything from chronic pain management, a really heavy over-reliance on medication, and GPs and others were keen to find other ways of managing that. Pre-diabetes and weight management, fertility and well-being, menopause, mindfulness, sleep, COPD, and also do a range of other initiatives like tea dances with local residents to combat loneliness and social isolation, working with the local council, care homes, and others. And that's sort of a fortnightly event that takes a couple hundred people to go. And then interestingly, I think what's developed out of that have been a series of other partnerships which are an interesting example of how something that in some ways is operating outside of the formal healthcare system can actually become embedded within it, which is that after COVID, we were approached by the local health and social care partnership around providing well-being services not to their clients. All of our programs are referred from local GPs and other healthcare practitioners, but also how could we provide services to their staff? And particularly out the back of COVID, a lot of them were understandably suffering from stress, anxiety, other issues. And so we developed a program within the local health and social care partnership for the treatment on an ongoing basis of, sorry, treatment probably isn't the right word, but around the engagement with their staff there. So a huge range of initiatives there, but to give an example of how that works in practice, all of the programs are free. They're free for the NHS, they're free for the clients. They are charitably funded, as it were. But they use the estate as part of the classroom. So as much as we have our Health and Wellbeing Centre, we have our health practitioners in-house, we also, because of our education centres, because of the other facilities on the estate and in nature, are able to do, I suppose, what would be called a version of social prescribing within the estate itself. So, for example, in our diabetes and weight management program, they're not just working with the team of health practitioners in the centre, but they're going out and they're working in our cook school, where we teach local young people about catering and hospitality, but they're going out and actually working with our team of chefs and education chefs around healthy eating, around how to prepare healthy meals. They're going out into our organic gardens and working with our gardeners and our education gardeners around their foods, around how they source their food, around how they cook with their food, around how sort of some of these sort of principles of healthy eating and similar. They're going into our outdoor center and our gymnasium and working with our outdoor staff about engaging in physical activity in nature, not in the gym, not going to the gym, but actually in the nature that surrounds them. How can they promote exercise and health and well-being through that? And that's just an example, but the idea being that within things like an estate, a historic site of 2,000 acres, there's the ability to build in engagements in health and well-being throughout that and to feed it into some of those more formal systems. These are GP referrals. These are part of a healthcare system. For the sake of time, I'm not going to go into how we do all of that in practice, maybe touch on it in the Q&A, but it's a combination of sort of engagement around self-care and management moving forward with workshops, group activity being quite key across a lot of these, forming communities within each community around their health treatments, around their health needs, even simple things like having people they can talk to who are going through similar experiences, et cetera, as well as a range of complementary therapies that they get while they're on our programs, and they also get for free on leaving our programs as well. So, I mean, that's just a very quick summary overview, but I think one of the things really is, and I think in here I reference heritage assets, but it could be a huge range of community assets, but how are these more than just bricks and mortar? You know, often things like this estates or some of our heritage assets or some of our community buildings are the only access to nature many people will get, or they're only the opportunity for social engagement. So how are we proactively building in, innovatively, health and well-being initiatives within these projects that sit not just in their own ecosystem, but feed into the healthcare systems that surround them? So I suppose that's the challenge. But thank you.
Thank you very much, Simon, and thank you to all our presenters today. I think it was a great set of complementary presentations with lots of inspiring ideas. So now it's over to you, our audience, and I'd like to open the floor to your questions, to our speakers, and I'd invite you to introduce yourself briefly when asking a question. So who'd like to go first? Who has a question? Yes, please.
Thanks very much indeed. I'm David Howard. I'm a fellow here at Kellogg. A question really to Ansaf, but it could be related to all your interests, and that's the impact and relevance of healthy new towns. So particularly, I'm guessing in Oxfordshire, but maybe East Ayrshire, etc., and elsewhere. In terms of the two healthy new towns, Bicester and Barton, you know, one of the 10 of the NHS's, well, the government's 2019 programme. How important are those two healthy new towns in your healthy place shaping initiative county-wise? So just generally, you know, how useful are they in many ways, and what's their impact been?
Yeah. Hello. So yeah, no, really good question. In a way, the two healthy new towns are the kind of pilot projects kind of started off the debate around how can we shape the place to actually create the better engagement with the community and improving health and well-being of our residents. There were some really positive outcomes that came out of that. So one of the positive outcomes was the engagement with particularly that kind of unmet need population and engagement with healthcare systems. That increased quite rapidly. So there was some really positive evidence-based outcomes that we saw over a shorter period of time. But as with these things, the benefits that you're going to see in a much more wider scale is going to be when you scale these things up. When you do it, and A, scale it up, you need to A, do it, B, do it in a much longer term to be able to see the benefit. And I think that's where it kind of fell through. But having said that, the key next step for us from learning from this is, I mean, Bicester and Barton were very different area. Bicester was more of a town, Barton is more of a community. The Barton, one of the things we realized is that, you know, splitting Barton in the way that it has happened, you've got a new development in one sector and the old development. I think that brought quite a lot of challenges, and there was lots of discussions about that. We also learned the importance of social prescribing around that and how do we involve the communities. So I think learning from that, but the next step is how do we apply this approach to areas of deprivation and underserved communities, because you don't necessarily, some of these communities don't lend itself naturally to redesigning of urban environment. It's more about how do you work with the community and the existing assets. So I think one of the things we have done is I know we don't want to work on this kind of ward boundaries, but it gives us something to work with. So we actually developed community profiles for these areas, these 10 areas, with the view of how can we implement some of the Healthy New Towns finding. And we did 3 things in each area. We got the data for that area, which we already have. Number 2, we engaged with the community to understand from a community perspective what the needs are. So not just what the data is telling us, but what the community is telling us. And thirdly, we mapped the asset for that area, which by triangulating those 3, we were able to get address some gaps in a way that is sensitive and relevant to the community. So it's absolutely go to the heart of asset-based working, really. And I think we are now in the process of doing that, and we will be evaluating that over a longer period of time. But to answer your question, in the short term, we saw some really useful engagement with the healthcare system. We weren't able to translate that into an evidence base that shows us improvement in the wider determinants elements. And I think that's where we need to try and, we know the results are there, but we need to do that over a longer period of time at a bigger scale. Hopefully that, yeah.
John Connolly, visiting fellow Kellogg College from Calgary, Canada. Thanks very much for the presentations. A couple of questions. First for Professor South. How do you reconcile the issue of socialization and social infrastructure in a pandemic or even an epidemic to be able to safely allow some element of socialization, given that we had such profound lockdowns in some countries, worse than others? I think speak about New Zealand and the issues of isolation and depression and other things, and then and how it could be done safely and for whatever futures come up and looking at harms and benefits. And then for Dr. Sadinsky, what do you do in an economically deprived area for maintenance and repairs on an old estate? How is it funded? Because the money's not going to come from your local community, I suspect.
Brilliant question on the pandemic. I think we're still learning, aren't we, about how communities, how resilient communities were, where people, that resilience was eroded by the pandemic and the effects of it. But some of the things that I've seen coming through research are the blending of, and it is blending, of digital and personal, personal sort of face-to-face, and how many community organisations adapted to draw in kind of both digital and the face-to-face in their organising. The creative use of, space, outside space, to sometimes bring people together. And again, it's sort of those ideas came from the communities rather than the government about how to manage that. And also, I've been doing a lot of work in this country around community champions, which are the sort of volunteers drawn often from more disadvantaged communities who did an absolutely fabulous job connecting with others in their community to spread messages about the vaccine and keeping well in the pandemic. And it's interesting that it went way beyond just encouraging people to have a vaccination. It was very much about hearing the stories from people coming through, and those champions were often sort of touch points so that services could understand how isolated people were getting through that, particularly if you're like a migrant worker or you're separated from your family in some way. So I think there's we're still learning about community resilience, but it definitely, some of the way in which some of those things evolve, there's a lot of learning, experiential learning from communities that would be worth capturing, because this is unlikely to be our only emergency.
Yeah, it's a fantastic question. Obviously, one of the biggest challenges always will be funding. I think I think looking at it holistically, so I think often you look at these buildings as, for example, as heritage sites in need of restoration and buildings that are in need of restorations, but they are also much more than that. They're much more than just the bricks and mortar. So for us, a big part of funding it has been what we did with the estate and what we do on the estate, and how we have, for example, with our education programs, taking over 15,000 students a year, through that generates an income for us, although much of it is heavily subsidized or free. We have a huge commercial business as well around everything from weddings and events through to a bed and breakfast, through to all of those sort of things. A lot of our programs are funded charitably through, for example, in the health program, the postcode lottery gives some, others give more, and through partnerships, be that with industry partnerships or commercial partnerships. And the running and management of the estate also, because it is such an educational opportunity. For example, we teach a lot around heritage skills, traditional building skills, things like that. So actually the process itself becomes an educational component, and there can be funding attached to that as well. So I think as individual initiatives, it can be quite a challenge, and certainly from the restoration of a building, quite a challenge. But if you build in this sort of ecosystem around the building itself, then that has certainly our case been what's allowed that to work financially. But I do think it is, we use this word sort of holistic a lot, and I think it's quite vague, but I think it is this idea that so often we see a lot of these things in silos, and I think we certainly see our health and well-being in silos, but we also see the places we inhabit, and our education itself is hugely siloed. But actually I think hopefully what we see and what we've tried to put into practice at Dumfries House is this idea that all of these things are fundamentally connected to each other, and if we see them as fundamentally connected, we can actually develop a really interesting structure around that. So yeah, it doesn't necessarily, I think each case is very different, so there's no golden ticket to how do you fund these projects, but I think for us, the diversified delivery and treating them not just as heritage sites, not just as bricks and mortar, but living, breathing parts of the community that feed into, just I think everyone around Dumfries House has some sort of story to tell about Dumfries House and the role it plays in their life. Either their kids got their first qualification there, their grandparents attend our tea dances, they attend our Health and Wellbeing Centre and had their first child in part through some of our fertility programs. Everyone has a relationship, and I think because it's that integral part of the community, whether it be fundraising, whether it be forming local corporate partnerships, whether it be forming other things, it's embedded in the place it inhabits and has generated a huge amount of support as a result of that. So don't know if that necessarily answers it, but that's it.
Hello, my name's Stuart Hall. I'm the head of social prescribing at Health Exchange, and I've recently finished a PhD in community ownership, so you'll see that reflected in my question, really. But I think running throughout the different speeches that you gave, and call them pitches if you will, I think there is a kind of recurring issue, and Ansar, you touched on it perfectly when you highlighted that in the 90s and noughties we saw this kind of pressure to educate communities and to pressure them to take responsibility for kind of social ills. And I think there is a risk that we kind of like responsibilitize them to deal with much broader issues around health and well-being. And Professor South, you touched on it when touching on resources as well. We know resources are unequally accessible for communities, yet we still apply that same pressure, and it's something that we see in social prescribing. So my question really is, how do we do this kind of work at place level? How do we work in different wards? How do we deliver social prescribing? How do we deliver, community-based health interventions when there isn't that equal capacity in the communities? How do we try and address that, essentially?
To take the first part of that, and I think, yeah, so look, usually people get drawn into evidence that you can measure and feel and touch, and usually there are quantitative elements. You give a pill to reduce someone's blood pressure, you can see the result straight away. And I think that's how we have grown to evaluate things, effectiveness of interventions. But if we do that, we will only do interventions that we can measure. And therein lies the problem. So everything that we do, we often have that kind of tangible element to measuring things, which are often short term. When you talk about something like social prescribing, and when you think about why did we actually go down the route of educating people, going from that kind of illness model to educating people to change behavior was a step upstream, harder to measure, but it becomes even harder to measure when you say what we need to tackle is the structural drivers of those behaviors, because you're not measuring one thing, you're measuring a number of things. But I don't think we should shy away from that. I think we should still take on the challenge. That doesn't. There's a big move towards actually measuring things in a qualitative way, not quantitative way. And I think people are now warming up to that, telling stories. I think that was really powerful. Some of the stories around the impact it has made. What I would say is that make that relevant to whether it's a healthcare system or whatever it is, that the system that you have in place. So if you think about it, one of the projects we are doing at the moment is it's called Better Housing, Better Health. In other words, people going to do home visits to address housing issues, but you also pick up a lot of well-being issues when you go into that. You know, what we are making the case is actually doing this will reduce the number of people actually getting admitted to hospitals, because we are addressing health directly by addressing the housing issues. It's very difficult to evaluate, but we are doing that. We're trying to now show the impact of that in terms of reducing hospital admission, which then suddenly gets the healthcare system interested. And I told you earlier, we spend millions of pounds daily in the healthcare system. So it helps us to kind of push the resources upstream. So what I would say is that whatever you do, whether it's social prescribing, find a way, whether it can be something small, find a way that you can measure and tell a story about an impact. And that will help to create a business case that actually tells you, if you invest on this, and if you do it for this long, this is the benefit you can realize. Because everyone knows prevention works, but no one can touch and feel the tangibility of that evidence. And I think that's what we need to do. And the last thing I'd say is that the health system are forming into what's called an integrated care system. That means integrating with the health systems are integrating with local government, voluntary sector, and wider organization to address health and well-being. That means, ultimately, allowing resources to flow through. So that it's in its early days, and I think we will see more reforms with time, but it gives us an opportunity to make these cases. Yeah. So.
I think part of what you're asking about is it ethical, moral, to expect people to be doing, contributing and communities we're working when we're not dealing with perhaps some of the wider determinants. What happens when community capacity isn't there, that particularly, and we've, where I work in Leeds, we've seen that, a loss of volunteers, a loss of community organisations, a loss of funding to community organisations that's really significant. And then at the same time, the health system is saying, oh, but could you do this more and could you do that more and so on. And so I don't think there are easy answers to this. What I do think, though, is that when we're suggesting, or I'm suggesting that we use what I call asset-based approaches or community-centred approaches like social prescribing, that it's done through that equity lens, that you're thinking about what needs to be there to help deliver that. And it doesn't stop you questioning whether the level of public services is sufficient and whether needs are being met. So for me, it definitely is not a DIY sort of solution. It shouldn't be about pushing onto the communities, which is why I think in my propositions I was trying to suggest that if we're thinking about where investment goes, we could think about like community hubs, because it's a way, or sort of community-based long-standing voluntary organisations that help deliver social prescribing often. That sort of investment into there will go directly to communities and enable that kind of activity to take place. We can't assume it's spontaneous. And the same with volunteering. The phrase I absolutely loathe is the army of volunteers, as if you can just, mobilise people and they, come out. And of course, we've seen that, in something like the Games Makers, for the Olympic Games. But when you're talking about prolonged community volunteering that's really addressing social isolation, that's really helping people campaign on the issues that are important to them, that's really reaching out to the most underserved communities, then you've got to invest in that over time to build it, good volunteer support and management. And we need to be saying these things, we want these things to work. But I think the outcomes from doing that are very powerful in terms of people's health and well-being, so it's worth making that case.
Thank you so much for that. Thank you to all our speakers for this evening and to our audience for engaging with us in this topic. Unfortunately, the seminar time is over now, but you're welcome to continue the discussions over drinks in a second. I just wanted to briefly mention that this is a seminar series. So we'll have the next seminar in the first week of Hillary term, which will be Wednesday, the 17th of January. And this will be chaired by GCHU Research Associate Dr. Catherine Maxwell, and it'll focus on COP28 and emerging themes from the conference. But for now, thanks again to all our speakers and to the King's Foundation for supporting this event, and thank you all very much for coming, and enjoy the drinks. Thank you.